Hello, all. Welcome to another episode of Directshift Story. Wish you all a happy new month, happy February. We are proud to begin celebrating Black History Month in February. And throughout this month, we'll be sharing stories from inspiring Black trailblazers, past and present. And so for the next 4 weeks, we'll be periodically paying tribute to Black leaders who made strides in their quest for freedom, be it in peace and justice as well. So this month we are highlighting Black men and women who are the trailblazers, who are positively changing their communities and the world. And in fact, the purpose is to focus on the African diaspora and the spread of Black families across the country. So this is also the 45th anniversary of celebrating Black History Month in the US. And today we have Dr. Clayton Ramsue. I'm like super proud. Thank you so much, Dr. Ramsue. He's a native of Philadelphia. He's a veteran of both US Navy and Air Force. In fact, after retiring with 25 years of service as a lieutenant colonel, he received his bachelor's degree in biology from South Carolina State University. His medical degree is from Morehouse School of Medicine and residency training from Mayo Clinic in Jacksonville, Florida. He holds a master's in healthcare management from Troy University and is a fellow with the American Academy of Family Medicine. Dr. Ramsue has held progressive leadership positions during his career, including senior medical officer, medical director, chief of staff, regional medical director, and vice president of medical affairs. It's an honor, sir. And over to you, Vamshi. Thank you.
Thank you, Raj. Thanks again for creating another pretty impactful episode. To all our viewers and our audience, happy Black History Month. Directshifts is very proud to celebrate Black History Month with all of you by highlighting some incredible Black physicians and leaders all throughout the month. And like Raj said, today we are honored to kick this celebration off by having Dr. Clayton Ramsue on our platform today. As you all know, Directshifts is a company that connects healthcare clinicians directly to employers. As a part of our mission, we have been bringing out stories of various clinicians as a part of this podcast. So today, we have a great healthcare leader, a great human being, a great family medicine, and a great clinician, a double hero who served our country and who served the healthcare space. I can go on and on. I'm privileged to have Dr. Clayton Ramsue on our platform today. And I'm privileged to kick off our celebration of Black History Month by introducing to you all Dr. Ramsue. Dr. Ramsue, I know I may not have done full justice to all the impact that you have created throughout these years. Please take a moment to tell us about yourself. And we are so grateful to have you on our platform today. And over the podcast, we'll be touching upon multiple aspects of healthcare, leadership, as well as diversity and inclusion. The topics that you mentioned are very close to your heart. So please take a moment and tell us about yourself and what you look forward to in this podcast.
Well, first of all, I'd like to thank you for the invitation. It's quite an honor for me to even be here, especially we're in Black History Month, and I think it's important that we celebrate all the heroes, period. Thank you for calling me one. I don't think I am one, but there are many people to recognize during this period. So my journey actually started I'm a native of Philadelphia, as you said before. My journey started as an enlisted sailor in the United States Navy. I became a hospital corpsman, then a surgical tech. After that, decided I wanted to be a physician. And when I was looking to be one, it was very rare that I found a physician that looked like me that could help me in that journey. There were several people that encouraged me, and I decided to pursue that. Went to South Carolina State University, at a historically Black university, college and university, and very, very proud to have gone there. Went to medical school at Morehouse School of Medicine, excellent institution, hello to Morehouse there, to all the faculty, alumni, and staff that are there, and got the privilege to serve my country again, and retired after 25 years of service. The things that are important to me, of course, are negating and decreasing the disparity in healthcare, especially among our population. Also, representation. We have to look at how we're represented as not only African Americans, but all the historically excluded groups in America, and also in healthcare, especially in healthcare leadership. And that's the niche that I have found myself in, to try to develop, teach, coach those leaders, healthcare leaders, especially clinician leaders of diversity for the next generation. And I'm proud to do so.
Thank you so much, Dr. Ramsey, for the service that you provide to the communities. I fully appreciate and know that heroes need no titles. But we, as the people that are benefiting from heroes like you, would like to call you heroes. There is a reason, why you just mentioned disparity in healthcare. You're a clinician by background. The impact of HBCUs in bringing forward more opportunities for all the Black populations. You touched upon also the need for diversity and more leadership from the minorities into the healthcare space, and in fact all realms of the world. For all those reasons, your fight for bringing all of this to the forefront, as well as serving the country and being a healthcare worker and a clinician and a physician, you're definitely a hero to us. Let me just reiterate that. You touched upon an important point just now, which is disparities in healthcare. And we all know there are statistics out there. COVID has disproportionately impacted Black populations compared to other populations. There is statistics to prove it there. How do you think the existing healthcare infrastructure, may it be the staffing, may it be the actual clinicians, may it be the access to healthcare, those things have to change in order to really tackle this disproportionate impact that not just the pandemic is having on some populations, but general healthcare issues are having on specific populations? What in your opinion should be changes to the healthcare infrastructure? Being a leadership coach yourself, what are you seeing in terms of the right changes that need to happen?
Well, I'm glad you asked that question. I think that it is not just one thing. I think it's multifactorial. We have to also realize that healthcare, and I think this is an extremely important point, healthcare is for people, given and administrated by people. And we have to put the human aspect back into that. We have to ask those hard questions. We have to say that that people need us. And what we're seeing now is that we have the highest physician burnout that almost we've had in centuries. And why is that? And we have to look at that. We have to ask those hard questions. So some of the things that I look forward to in changing the healthcare continuum as it is now is that we have to start asking the hard questions, and we have to start out by being truthful, because you cannot go forward if you do not know where you are right now. And I think those hard questions are starting to be asked right now, because if we're looking at staffing, let's take the components that you alliterated to. If we're looking at staffing, well, 10% between African American and Latin populations, we make up 10% of the physicians in the country for 30% of the population. Right. Those numbers alone say that there's something that needs to be addressed. The number of African American males that are currently in medicine, 2.5% for 7% of the population. We have to look at those numbers. We have to start to address those. Some of those are in forms like this, that we are able to present ourselves and we're able to be seen. Sometimes you just need to be seen. I had the privilege of interviewing a potential medical student, and they were African American descent, and they told me that at 22 years old, the first time that they saw an African American physician was a year ago. There's something wrong with that. So we need to not only be seen, we need to be heard. We need to make our presence known. We need to ask the hard questions, and having that integrity to do so, it comes with a cost. There is nothing that is worthwhile that does not come with a cost. And that cost for us is sometimes where we're not going to be popular. And I'm not in this to be popular, but I'm in it to make a difference. We have the charge to speak for those people who cannot speak for themselves. And that's what I'm here to do. And that's what I'm encouraging other physicians to do, clinicians, nurses. I mean, there are so many frontline heroes that, you know, the custodial staff, the maintenance staff, they're working overtime too. They're in this with us. And we have to understand that now it's about people. You know, we love AI, we love technology. It is a tool, but we have to get back to the people aspect of it. To use an analogy from Six Sigma, you start with the end in mind. What do our people need to go forward? What is not being done, and how do we address it? And it's going to take more than one mind to do it. It's going to take collaboration. It's going to take understanding. It's going to take listening to each other in order to even move the needle at all.
Completely understand, Dr. Ramsey. Thank you for sharing those points, especially it's for the people and by the people, and the human factor has to be forefront. And keep the end in mind and work backwards so that you can design the right strategies to improve that access. Absolutely well said. Just one point with regard to that. In one of our previous discussions, it was stated very rightly so that just by creating access to now multiple areas where you could go get healthcare, or potentially inserting technology into improving access, it still does not solve the problem, because there is history to why people are sensitive to certain cultures, why they're sensitive to certain areas, certain people. The cultural sensitivities of the people have to still be addressed. It is still not easy for people to come out of it and then just still use the resources that are being made accessible to them. You just cannot think by now making more resources accessible to, you know, these populations that have traditionally not have had the opportunity to access the right resources. You cannot think the problem is solved, or by inserting technology, the problem is solved. The sensitivities of all of these populations, the different determinants of health that are coming across now, in my opinion, it cannot just be social determinants. I think it should be racial determinants of health, cultural determinants of health, social determinants of health, economic determinants of health. All of them have to be clubbed together. Can you tell us your opinion, Dr. Ramsue, on how currently, even though the resources may be increasing, although there is still shortage, it still does not solve the problem until you actually take care of those sensitivities that these populations actually have in order to access those resources?
I'd be happy to. One thing that you mentioned is to ask those, you know, as we talked about before, answering those hard questions. And are we asking those questions? Where are the at-risk populations? There has been increasing education on cultural competency. And I think that, you know, some of that will go forward. And I think it's necessary. And if we're looking at leadership, and this is a topic that I would really like to talk about, and we'll talk about it throughout this interaction. Who makes the decisions about where the resources go? Who has access to them? So how can you represent me? And we can even use another topic. I'm also a veteran. So if you are trying to address veterans affairs, if you're trying to address me as a veteran and you have no idea what I went through, and you're not a veteran, but you're making the decisions about me as a veteran, how can you do that? Okay, we take that same example and we put it to cultural competency. We put it to representation of historically excluded groups. How can you represent my population and serve my population if I'm not at the table helping you to make those decisions? And you know, I think that's a book topic that I want to work on. You know, don't just invite me to the dance. Let me help you plan what's going on, because I have a vested interest in that population. I have a vested interest in the veterans population. I have a vested interest in African American population, in all minorities or population. I have a vested interest in that, so I'm going to try to make sure that they are looked at, or ask them the question: what do you need, and how do you need it? Help me solve the problem. The problem solving doesn't come from just us as administrators or us as clinicians. Again, starting with the end in mind. What does the patient need? What are they not getting? It's okay for me to set up an appointment but what if they can't get there? Or what if they get there and I prescribe something, but they can't afford the medication? We have to start thinking about healthcare itself as a continuum and not as episodic care and not as sections of care. From the time that you have actually earlier than the time that you have illness, let's start with your health. Let's just talk about preventive medicine measures. Let's talk about how come in certain populations we don't have a Whole Foods or Sprouts where we can make healthier lifestyle choices. Let's start there. If some of the initiatives that I love, there's a barbershop initiative going on in several communities. As an African American male, I go to the barbershop. Well, I used to go to the barbershop before I got, shaved my head bald before COVID. But I would go to the barbershop and we would have philosophical, and political discussions in the barbershop. Why can't we turn that in? And those have been turned into health discussions. I think that's brilliant. Meet people where they are. Take them to where you want them to go. That's the approach that we need right now. I cannot solve your problem as a patient if I don't know what your concerns are. And again, bringing in the people aspect of it. Technology is fine. Technology helps us do all the things that we're doing now. It helped us with the crisis, but it was the people that stepped up in every aspect. It was the people, and we need to reinsure that we're taking care of the people, not only the people that need our help, but the people that are doing the helping. When was the last time, and I hear this from clinicians all the time, and I ask them directly, when was the last time you were asked, where do you want to go in your career? What makes you happy? Or what makes your job harder to do? I can come up with policies that meet criteria, that meet regulations, but when I administer them, how do they affect that interaction between you and the patient? I've been an advocate of telemedicine for years and wondered why it wasn't bigger. Telemedicine has been around for 22, 25 years. I encountered it in the military. I encountered it in residency training. So what took so long for it to become an acceptable patient encounter? It had to do with finances. Who was paying for it? That can't be the thrust of what we do. We're not going to solve any problems in healthcare by just concentrating on any dollars. If we concentrate on the people, if we concentrate on the needs, if we concentrate on trying to give efficient, essential delivery of healthcare products, that's where we're going to make the difference.
That is absolutely well said. That reminds me, Dr. Ramsue, of a very impactful statement one of my friends made a few months ago when I was dealing with helping organizations from Directshifts. We were dealing with helping organizations procure staffing to take care of the COVID task force. One of my good friends, who also happens to be a physician, told me, the purpose of business of healthcare is not to make money. It is to use money as a tool to improve people's health. Absolutely. You exactly said the same thing, which is people need to be at the core of the actual business of healthcare. Go meet the people where they are, understand the needs, use that as the end point and work backwards to now design strategies. That's with that, I'm trying to continuously ingrain that in my brain. And that's, again, very well said. With that as a core, there are still leaders out there, very impactful healthcare leaders, probably with the right intentions to improve healthcare outcomes, etc., but end up defining quality of care with some standard quantitative protocols and are unable to really incorporate the people's needs into those definitions of quality of care. In your leadership coaching, Dr. Ramsue, for all the viewers out there, you can see at the background, Ramsue Consulting Group. Dr. Ramsue is also a healthcare leadership coach. I would encourage every one of you to go check it out, with a lot of impactful, transformative leadership coaching happening as a part of Ramsue Consulting Group. So as a part of that leadership coaching and consulting, Dr. Ramsue, how do you help healthcare leaders move away from completely and only determining quality of care through quantitative metrics, but incorporate the actual understanding of patient care needs and the patient populations into their definitions of quality of care?
Well, I think that's an excellent question. And it's a very, very tricky one because sometimes you have to, those quality measures are linked to reimbursement, which is linked. So when we're linked to money and we're linked to reimbursement, sometimes those quality measures are mandated and regulated by CMS for payment. But in saying that, we're all charged up about big data. Everybody says, "Oh, we need big data." So what are you doing with the data? What does the data mean? So it has to pass, for me, it has to pass the 3M test. So 3M test for me is it meaningful? The data you're collecting, is it meaningful? Is it measurable? And is it modifiable? If it does not meet those three criteria, then that's probably not something a metric we need to use. Because if you can't change, let's just take any one of those parts. If any one of those parts is missing, then functionally, it doesn't work. So if you have a metric that you're measuring that is not meaningful, you're just collecting data. If you have one that's not measurable, well, how do you know if you're getting to your goal? If you have one that's not modifiable, so you're collecting data that you can't do anything with. So I think it has to meet those three measures. And we have to get back to, again, relationship. And when I talk to my clients, my coaching clients, we have to make sure that, and I think burnout has a lot to do with it, but we have to make sure that their core values, again, we're talking personally, your core values match up with what you're doing at the particular time. And I think that's where there's a problem. People's core values change over time. When I first started this, I didn't have children, I wasn't married, so things changed. So family values became a part of what I see as my core values. So I have to align my career. So we spent so much time, because we're so linear in our careers. We're told to go to undergrad, we're told to go to medical school, then we go to residency and maybe fellowship, and then they tell you to go to work. And then 7 to 10 years later, these are the clients I get saying, okay, now what? Is this all I'm supposed to do? What other things that I have to do? So there's several pathways that I go through. One is identifying your core values. You have to know what those are, because if you're going against those, then you're going to have a problem down the line, and that creates frustration, that creates aggravation, that creates anger, which may create in turn your burnout. Then we talk about, well, where do you see yourself being? What would be ideal for you? There's so many parts. I've met so many clinicians that have so many wonderful parts to them, including I've met some that are songwriters. I'm talking about Grammy award-winning songwriters, but they're also physicians who are musicians, who were star athletes, who were Olympic athletes, but they don't bring their whole selves to work. They think that the biggest mistake that organizations make is to treat the clinicians like a full-time equivalent, an FTE. They're much more than that. And if you want to get more out of them, then you have to treat them as such. So I asked them what is your ideal, and what does that look like? And you'd be surprised how many times I ask those first two questions that we have to go to another session, because they haven't thought about it. They haven't taken the time to think about it, of where they want to go. What would be ideal for you? Do you want to go into research? There are some physicians that I coach that are phenomenal teachers, but they're not teaching. But that is what they actually love, and that's where they excel. So I try to line them up, try to get them to line up, because the chief tenet of coaching itself is that you can solve your problem. You have the answers to your problem. I just shine lights on possibilities. So you've been on the yellow brick road going down there. So right now we're going to go off-roading, and we're going to look at some other possibilities. So my job is to open up your realm of possibilities and have you think about some other things that would maximize your fulfillment within medicine. And that's why, there's nothing like seeing a physician that is unhappy seeing patients. That is not a good experience. And how can we gain back that patient experience? How can we gain back that joy and that fulfillment within healthcare? By aligning what we're doing with our core values. And then as we looked at, I helped them create a roadmap to follow with actionable items for their next step in their career, whether it be leadership, whether it be going into research. Sometimes it's just not being in in that particular facility. And sometimes you just don't, and sometimes it's going back to get additional certifications and degrees. I was one, as my mother also always jokes that, I couldn't get you to read a book hardly, when you were in high school, and now I can't stop you from getting certifications. The irony of life itself, because you have a thirst for knowledge, and you see different, as you go along, you see different pockets, and you see different gaps. And I want to know more about those gaps, and I want to get more knowledge about those gaps. And there are a lot of other clinicians who are just like me, who are doing some wonderful things out there, but we need to highlight those. The first thing is to identify that you are not happy where you are, and be willing to do something about it. Once we get to that point, the rest is very easy. The rest of the job is easy. It's just execution.
Great point. Well said. I totally appreciate you not only have the thirst for knowledge, Dr. Ramsey, you also have the thirst for sharing it. Thank you for that. And you mentioned the point around a lot of these core values should be incorporated into leadership coaching, and what leaders look at as important things for them, especially in mentoring clinicians to look at this holistically and not just with a parochial view. Having said that, we have worked with a lot of healthcare leaders as well. You mentioned who makes the decision. A lot of leaders who make the decisions. Couple of arguments that have emerged out of these discussions have always been, well, we have the metrics in place. We have the revenue metrics, productivity metrics, quality metrics, patient experience score metrics. We have all these things in metrics, which are the quadruple aim related metrics, the IHI's quadruple aim related metrics. We have them in place. Those metrics should take care of it. So we are doing everything that needs to be done. So there is really no need to change how we approach some of our care mechanisms, some of our leadership mechanisms, or some of our implementation mechanisms with respect to quality of care or accessing the patients and understanding what the patients need. Is that sufficient? Is having metrics to the quadruple aim that many organizations follow now, is that sufficient? Let's talk about especially primary care or preventative care, which is the foundational care mechanisms, the first touch point a patient would have. And then we can probably go into the acute care as well, secondary, tertiary cares. But specifically with respect to the primary care, are those metrics good enough to really impact and make sure the patients are getting the outcomes that from a health perspective?
I think that's also a good question, and as you know, that's being studied continuously. That is not a one-time look at problem and then we've solved it and then we move on. But I think it needs to be looked at as from several different perspectives. Metrics, I consider guidelines. They are. I entirely respect and have been around in practice when evidence-based guidelines came along. And at first, the change was, oh, well, why are we doing this? Are they telling me how to practice medicine? No, what we're saying is that based upon the data that we've collected, your outcomes will be better if you can follow these guidelines. Now, with respect to guidelines, there's always room for clinical judgment. That's where, again, the person and the people come in. So a guideline alone or a metric alone doesn't solve any problem for a person. So if you so I had an experience with one of my parents with a cancer diagnosis. So if we follow the metrics, if we follow the metrics, we follow the guidelines, she got better. But when we're talking about recurrence, is that metric, we think about when she thought she had a recurrence, did that metric make her feel any better about the possibility that her cancer may have returned? Did it help? Yes. Did it solve the problem? No. Did it make her feel any more confident about what is happening to her? We really have to get back to understanding that illnesses, healthcare happens to people. You tell someone that they may have recurrent cancer and they stop, you can't say anything you said after that point, they probably didn't hear. They're trying to figure out, how can this happen to me and what can we do about it? And so what comes there? The support. The making sure that that your support system is lined up, to make sure that you can get to your appointments, to make sure that you can get fully diagnostically evaluated. So that's not just metric. So metrics are good. I think it keeps a lot of us in line, but we cannot make decisions based upon, just like we make decisions based upon just data. No, the numbers don't lie, but they don't tell the whole story either. So that's why you have people involved, because even if you're talking about, I was, worked in Medicaid for insurance Medicaid, and why would you have a suite full of medical directors that go over some of the parameters that don't meet the screening nurses, the utilization management nurses computer screen? Because everything doesn't fall into an algorithm. When it falls out of algorithm, that's why the medical director is there to have that conversation with the clinician to see what the best approach is, most reasonable approach, evidence-based approach is for that patient. We need to add the people to the, metrics or guidelines. We need to add the people to that. So
great points. I think metrics are guidelines. We need them. The numbers don't lie. They don't tell the whole story either. You always have to have additional mechanisms to appreciate the true needs of the patients, to be more culturally sensitive, racially sensitive to the patient's needs, while looking at the metrics that will help you as guidelines in your operations. That's absolutely well said. Along the same lines, I've always wondered, Dr. Ramsey, I would love to get your opinions and observations on this. Like value-based care, the way it has evolved, focus more on the holistic outcomes versus fee-for-service, and which by intention and design, it's a great model to evolve towards, so that you're actually focusing on the health outcomes, which the business of healthcare should be focusing on, versus fee-for-service, provide the service, get the revenue. So it's a great model. I think a lot of us appreciate that it's a great model. Having said that, has that model penetrated enough to appreciate people's needs to the extent that it should be? Have you seen that model really making an impact in the Black population's health outcomes, or is it still not evolved to the extent that it's supposed to in those populations? Especially, I tend to believe personally that value-based care has to have bigger impacts in populations that traditionally have been underserved with respect to healthcare. And you were mentioning these statistics, 10% of Black clinicians, physicians versus 30%, or Black and Latino versus 30% of the populations, 2.5% of Black male physicians versus 7.5% of the whole populations. So automatically we are seeing disparities, in certain populations and in healthcare.
Right.
And I personally think that value-based care should be focusing on closing those disparities more, take more value-based care towards those populations versus focusing on populations that are already better served with respect to healthcare and health outcomes. So my point here, my question to you is, are you seeing value-based care as a potential alternative, a good alternative to just focus on quantitative metrics and providing healthcare to that? And is value-based care evolving towards really producing better healthcare outcomes? And is it penetrated enough in the populations that have traditionally been underserved for healthcare?
Okay, so I'll take those in parts. So as a model, value-based care itself, has it penetrated? First of all, has it penetrated the market of healthcare enough? With outcomes that we have now, you can look across the nation and know that it has not penetrated enough. There's no discussion about that, and a lot of that is because of change. We're looking at we've done value, we've done fee for service, we've done the other models for years and years and years, and now someone comes into you and said, okay, well now I'm making you a full risk for the outcomes of these patients. Okay, well you just told me 20 years ago that I couldn't take, for the last 20 years, I couldn't take full risk, that if I didn't have a specialist, we were going to court, I was going to have something on my national practitioner data bank, but now we're changing this around. So again, similarly with pain as the fifth vital sign. That's a whole different thing that I remember when they were taking us to court for not treating someone's pain, and now we're in the opioid epidemic. So in the same lane. Yeah. So is it really addressing our population? I don't think that that the historically excluded groups, that it's really penetrated that population. Are there models that are going to that now that are working? Absolutely. Going back to one of my first statements is that if you have to look at healthcare as a continuum, and when you are dealing in a value-based model, you're dealing with that continuum. So what I'm trying to do is, one, keep you healthy. So I'm trying to make sure that I'm addressing your weight. I'll make sure that I'm trying to address your lifestyle. But before we get into trouble, then I'm responsible for you during that continuum. So it behooves me to make sure that I have coordinated care within that model. So the coordination and the continuum. So one of my biggest pet peeves is being discharged from the hospital. I think there's such a gap between the time someone is discharged from the hospital and we could just look at readmission rates on billing data to know that the readmission rates are too high. We have data that says that if I contact you within 48 to 72 hours of your admission and I do a medication reconciliation, which is one of the primary reasons that people go back into the hospital, because they don't know how to take the medication. I have this bag of medication before I went into the hospital, my medications were changed. Now I have 2 bags of medication and I don't know which one I should take and when. It sounds simple, but it is difficult to administrate because if we don't focus on it. So I think that the value-based model, I think it has merit. Is it penetrated the way in a manner that it should be penetrated at this particular time? No, we're progressing to that and now we're collecting. There's some forums. I mean, and I think we've done it better. If we look at examples, I think we've done it better in the senior population. So if you look at some of the senior population, some of those organizations, and unfortunately I can't mention their names, but some of those organizations have really taken that value-based model and they've shown, and they have data to show that it works. Their outcomes are better, even though they have a high risk population, because let's face it, as we get a couple more mango seasons under our belt, we have more problems and we're not going to live forever. So sometimes, that transition of life is something that happens, but they are proven that it's better and that the care is better, their outcomes are better. So I think that, I think it's a start. I think we need to target it in some other populations, but it's going to take some administrative push in order for us to do that.
Yeah, absolutely. I think those are great points. And you mentioned that.
Vamshi will take this quick question from Mrs. D. Thank you so much for listening to this live. This is for Dr. Ramsue. I'll read the question. Is it realistic to expect that we'll be moving to value-based care when the entire process is so focused on dollars and fee for the service?
Excellent question, and thank you for that question. I think we will move to fee for service. I think it will be, we move to value-based care. Will we move to it totally this year? Will there ever be 100% penetration? I don't think there would be 100% penetration. I think there are some other considerations with that, but I think you will see progression. But what we want to do is I think it will come out with patient choice. I think if you give people options, and word of mouth is still the best marketing that there is around. So if you hear someone say, as I'm getting closer to my AARP, I'm already AARP, but getting closer to being considered a senior citizen, going to one place and getting most of my healthcare needs taken care of in that one place with people who I know and who know me and who have a vested interest in keeping me as healthy as possible. I think that will catch on, and I think that'll catch on because we made the decision, and not only as patients, but consumers patients and consumers are much more informed than they were before. They're taking control of their healthcare. So I think it will penetrate. Do I think it will be all the only aspect of healthcare that we have in the next 2 to 5 years? No. I don't think it would be totally what we have. But again, that's a speculation. I don't know what the government will say. But I think we'll get more penetration. It will be adopted more, but I don't think that would be the only venue that we will have.
No, it's a great point, Dr. Ramsey. I always tend to think about it along the same lines, which is the 4 Ps are the 4 powers of healthcare: patients, providers, payers, and policymakers. The four Ps, the four powers of healthcare, have to move in the same direction with respect to the value-based care. There is no other way this can be achieved. And that's a great question, Mrs. D. Thank you for asking. If one of them is headed in a different direction, the whole value-based care outcomes cannot be achieved. That's I think that's the intention of when it came into place, was that all these four will move towards that direction. Having said that, my question, or one of my observations, is value-based care has always had the risk calculation attached with it, right? Because it's all about assuming that risk. I wonder, are there algorithms running at the back of whoever is implementing value-based cares to potentially not choose more risky populations and still be on the safer side with respect to implementing the value-based care models? If that's going to happen, then one of them is not going in the same direction as where the outcomes need to be headed. I just wondered always, I frankly do not have data, but I've always wondered, is that happening? If that is happening, how can trainings and designs take care of this at the source, so that it is agnostic to certain risk algorithms, but it is actually, or potentially even, encouraging people to take the model more to the high risk populations versus the other way around?
That's a good question. And I don't know if that is happening. I can't say for certain at all if that is happening in the background. But what I can say is that a lot of the value-based models that we have right now are with some of the most at-risk populations. So one, we know it works. We know that we know that there are good outcomes from this model, because what a lot of these companies have done is take the most at-risk population and manage that most at-risk population, and come back and said, look, my outcomes are better. My diabetes population is more well controlled. My hypertension population is more controlled. I have less hospitalizations. And if I do have a hospitalization, if I do have an ER runs, because they look at ER rates also and admission rates. When my people do have to go to the emergency room, their admission rate is higher, so they really do need to go. So with those, if you are starting your model, if the majority of your model right now and implementation is with those really, really at-risk populations, and you're showing that it works, are there going to be some people, you can't have a business model where no one decides that, oh, it's smart for us to cherry pick who we choose and who we don't choose. Somebody's going to do that, but I can't say that that's happening now, and I don't have any evidence to say that that's happening now.
But it is great to hear from an expert like you, Dr. Ramsue, that wherever it has been implemented in some of those high-risk populations, it has shown results. Absolutely. I mean, that's a great start. I mean, it's reassuring to me. Forget all my healthcare presence aside, as a common man, it's reassuring to me that the value-based care models, wherever they're being implemented, especially in those high-risk populations, it's working. And you mentioned a lot of use cases, examples that the model has worked well in the senior population. And we all know how disproportionately our senior population was impacted during pandemic, and that has exposed the access and quality of care, a lot of healthcare issues in our senior population. And if models like this will continue to work in such high-risk populations, it's always reassuring to the common people that the policymakers and payers and providers and all of us are moving in the same direction. Absolutely. It's a great point. Now, coming a little bit to the technology enablement of this, Dr. Ramsue, as a lot of our viewers and audience may have already learned, Dr. Ramsue is a healthcare leadership coach. He's a clinician. He's also an innovator. He is, like he said, he has adopted telemedicine years before it actually became even a thing. So he's an early adopter and innovator. So from a technology perspective, we are seeing a lot of technology enablement of the insurer technologies, the payer technologies. There's a lot of technology enablement of the patient care itself, remote patient monitoring, helping value-based care, and potentially telemedicine now improving access to primary care, telemedicine improving access to mental health, and all those things. Right. So for a lot of those because of a lot of those technology advancements, we are also seeing more technology players coming in, starting to flood the healthcare space. What would, as a clinician and as somebody who has fought for the people-centric healthcare for many years, what would your recommendation be to all those technology players trying to flood into the market? It might be a good thing if they do it in the right way. What are you seeing, and what is your recommendation to such technology play in the healthcare space?
I think I knew the flood was going to come again. It took the telemedicine technology. The theory behind it has been around for over 20 years. The military has used it. Residency programs have used it. Why did it become so popular? Well, one, based upon necessity lately, and then even with that necessity, people started paying for it, as in third-party payers started paying for it. Well, then that's when people come, when there is an opportunity to make revenue from that. So, the new entry players into that telemedicine space or to the technology market, I asked them a chief question: what problem do they solve? What do they do for the patient? What is their responsibility and opportunity and obligation to the provider of that care? Because there, in some of those, there is a disconnect between those also. So not only this, there's another market that's coming up that, in the cannabis space, that you'll see that way gains in the market. And if you don't believe it, then watch the start market, because that's going to be one of the next emerging markets because of medical marijuana and things of that nature. So what are you doing for the patient? How is this a greater patient experience? And have you been a patient? You'd be surprised how many telemedicine companies have had their leadership not ever had a telemedicine encounter, a real one. I mean, a one that they needed, that like they were sick and they went to a telemedicine platform. And then from there, because a lot of it comes from experience. If you haven't experienced what your patients need to experience, then that's a problem. How are you dealing with the providers? How are, who are helping you with this service? Are you creating a patient experience that is more efficient? Are you creating access? Are you creating more technology? Are you creating ease of process? Answer those questions first. So the question I want them to ask themselves is, how are you benefiting? How are you benefiting the people that you're serving first before you benefit yourself? And I think that's going to make the difference in it, because we need these access. And I think people have to understand that, are they coming in to take over and change the way we do medicine? No, I think these are excellent adjuncts, because people still want, again, going back to the people aspect of it, people still want to see people. But I want to have access to you, and I want you to have access to me to address your needs. And I think that's what people have to understand. These entry players, and how are you creating a different experience? How are you different? Just like a job interview, why you, and what are you doing that's so different that I should choose you? That's what people are going to gravitate to. That patient experience, and from the provider side, the big thing is the compensation. So you're charging someone $150 for a visit, that patient, and you give the clinician $30. So, and the clinician finds out about it, and you wonder why, there's turnover, there are things like, so let's bring some common sense back to medicine. My mother always says that common sense is not common. I didn't know at the time she was saying it, that she was actually saying it about me personally, but we have to bring some common sense back to things. Let's ask those questions. Let's do things that make sense. And people, when people tell us things that don't make sense, let's challenge that. Let's ask a secondary question and say, well, that doesn't quite make sense. And how does it benefit everybody around? There has to, in order for me to stay with you, people don't leave institutions, they leave people. If I feel as though that I've been wronged by you, if I feel that, that you don't respect what I do, you don't respect my knowledge, you don't respect what I bring to the table, then I'm going to leave. That's the same for a patient as it is for a clinician. The same thing.
That's a great point. People leave people, not institutions. So how do you make your operations more people-centric? And you brought up a good point, which really nicely alludes to some of the price transparency mechanisms that are being implemented, or there is attempts to implement those things. We at Directshifts, we have seen a lot of those adverse events as well. Pretty much in the staffing industry that we are in, we connect clinicians directly to employers to pretty much bring that pricing transparency. Like, what as an employer you want to pay to some of these clinicians, to some of these healthcare workers, what as healthcare worker do you expect to be paid? Let's make a connection. Let's make a match between those two based on those expectations, profile and preferences, and all those things. That's what we do. And we have seen that. I think we firmly believe there is a need for pricing transparency in the staffing industry as well. There's a lot of price gouging that has happened forever. That's one of the reasons our mission exists, which is create better pricing transparency, better convenience and liquidity in the market, so that enough clinicians who we all know are short in the market anyways compared to the actual demand, so that they can actually go pick up staffing opportunities or job opportunities in areas that have traditionally not had the right access to the right talent. That's one of the reasons that we exist. So what you're saying with respect to the price transparency, making sure the people really do not feel they're wronged, people, they have the information that they need to succeed. That is something that we encounter on a day-to-day basis. Absolutely. I think that's the same thing with patients as well. And if I heard you clearly, Dr. Ramsey, what you're saying is for all those tech companies out there that are trying to come in to potentially do their part of disruption, make sure you always ask the hard question of what you're doing to the patient, what are you doing to the clinicians, etc. And how we have potentially always tried to solve that problem is have enough clinicians, enough customers give us more feedback. Like, tell us, how could we improve?
Absolutely.
The fundamental belief that we have is if it is not with you, it is not for you.
Excellent. I think that's excellent. And I think that we have to understand that collaboration is key. We can't do this alone. We can't do it in isolation. We can't do it in our silos. We've done that, and you see where we're at, where we are, and where we stand. So I think the leaders of the future. I think that we're going to come out of this crisis. I think we're coming out of it stronger. Innovation is going to be key. And not only innovation in technology, but innovation in thought, looking at different perspectives. The people who are able to garner opinions from a wide range of people to help solve a problem, to help come to a solution about the problems in healthcare are going to become immensely successful. The organizations that realize that one of their chief assets, they have two chief assets. One is the patients that they serve. The other one are the people that work with them and for them. Once you understand that these organizations are made up of people that have families, that have needs, you can understand that the control of actually the motivation, the control, the stimulation of only 10 inches of the most important real estate that we have, which is our mind and our heart. Those are the people that understand that, the leaders that understand that. They're going to be the ones that are going to be successful because they're going to be nimble. Why are they going to be nimble? Because they listen to the people that work with them. They listen to the people that are actually doing the work. And you came to an agreement. You presented what you have to get done. And because, here are the parameters, I have to get this done. I have to complete this mission. I want your opinion about how we can best complete it without breaking rules, without causing commotion. How can we do this and make it smooth for you also? That's collaboration. That collaboration is going to lead you to success in the future. And those companies and those leaders that can do that and you garner that and also have, show the respect and admiration and also development and education is key for your staff. You're developing them, you invest in them, you actually know who they are. You want the best for them. Those are the places that are going to flourish. And those are the organizations that are going to succeed. Absolutely.
Absolutely. I'm going to steal one of your statements, Dr. Ramsue, the 10 inches of real estate. That is really important to us, our mind and heart. I think it's important that we all remember that and make the most out of that real estate and make sure our IQ and EQ are always in the right place with respect to running people-centric operations. Perfectly said. Thank you for that. Although I could do this for the entire day, I just want to limit this to one last question. For sure, I promise this will be the last question.
No problem.
As you know, and all of our audience knows, this is the first of our celebration of the Black History Month. We are extremely happy and proud and privileged to have Dr. Ramsue as our first guest speaker in our celebration of Black History Month. And this time Black History Month's theme is Black family representation, identity, and diversity. So, Dr. Ramsey, for our audience out there, with this as the theme for the Black History Month this time around, and we all know there have been historic challenges on all three aspects. Representation, let's take just healthcare. There's been challenge. You gave us a lot of statistics that clearly talk about those representation challenges, potential identity challenges and diversity challenges that still exist in the healthcare space, maybe on the workforce side of it, or on the right representation on the patient side of it to understand their needs. Those challenges still exist. And we are so glad that the theme really reflects the challenges that we have today for Black families, representation, identity, and diversity. So what, in your opinion, should, in terms of from the healthcare perspective, what should happen more in order for representation, identity, and diversity to improve in the healthcare space? What do you personally want to see more of that we all should take a note of?
I think essentially we have to understand one thing about life in general. It is the acquisition, the development, and the maintenance of relationships. And I think that's important not only in the African American community, but in every community. So we have to encourage people from an early stage. Some of the disparities that we're seeing, some of the misrepresentation or underrepresentation of historically excluded groups within medicine happens at such an early age. It didn't happen in high school. It didn't happen at college. It happened in elementary school. It happened to me. Luckily, I had a third grade teacher that told me that when I read out loud, I sounded ignorant. So to this day, that sticks with me. Before I give a speech, I still hear that in my head. So we have to understand that messages matter, words matter. So does mentorship, so does coaching, so does interaction, so does people are looking at these big things as far as leadership is concerned with the John Maxwell's and things of that nature. But let's make it simple. How about you just encourage someone today? Who did you help today? When you wake up in the morning, said that before your day is done, that you're going to help someone. There is someone out there waiting to hear your voice. You do not know who that is. And as a clinician and as a physician, we need to represent that. We need to get more African American males into medicine. That's one of my charges. We need to have more representation in leadership, especially if you look at the Fortune 500. You just look at the executive leadership page. That it does not reflect the patient population they serve, and it does not reflect even their workforce. Training, development, telling people that their opportunities are there, widening people's scope. A lot of people don't even understand the potential for leadership that is out there in medicine. I know some of that thing. I know more people that know more of that. My job is to expose them to that and give them all the help that I can give them so they can access that. So help where you can, do your part, make your voice known, fight for those who can't fight for themselves. And I think we'll see a change.
Thank you, Dr. Ramsey, for those powerful words. In the best hope for change going forward, I really want to end this show, and we are profoundly grateful for having you as our first guest speaker as we celebrate the Black History Month. And a leader like you, a clinician like you, and a veteran like you, we salute you for all the services and all the things that you continue to do to create impact in the community. Thank you so much for being a guest with us. And I hope we can talk more and more about all these things and bring more information out to the world.
Thank you, Vamshi. I really appreciate the opportunity. And hopefully we can work together in the future. If you need me, you know how to access me. Thank you very much.
Absolutely. Thank you. Raj?
Yeah, thank you all. If you're still watching this and if your question is not answered, please inbox us. Thank you, Mrs. D, for watching this live. I know that your second question is still there, but do watch this on Google Podcasts and on Apple Podcasts. And you can always inbox Dr. Ramsue and Vamshi. I'll text you through YouTube comments. And for all the people out there, happy celebrations. Let the entire month. It's not only the month, as everybody says, let's celebrate for entire year. Let's celebrate it for life in every breath we take. So thank you so much for tuning in live. And if you're watching the replay, please do share, like, and comment with the community and the friends and the family. And I'll see you with another episode of Direct Shift Stories. Thank you, Vamshi. Thank you, Dr. Ramsue. It's an honor. I love
No, my pleasure.
I had
Absolutely pleasure.
probably everybody out here also who was watching, a couple of them, they all had goosebumps, but we'll keep talking to you. Thank you so much. Thank you for staying live and keep watching other episodes of Direct Shift Stories. Thank you all.
Yes, sir. All right.